name is Riccardo CAPPATO. I'm currently the director of the Research Arrhythmic Center at Humanitas Hospital in Milan, Italy. The topic that I was required to cover today was a critical review of the use of defibrillators and cardiac resynchronization therapy in patients with congestive heart failure. With implantable defibrillator, the evidence is substantially in favor of this technology in the vast majority of patients with congestive heart failure, particularly with ischemic cardiomyopathy, but also with non-ischemic cardiomyopathy. I briefly touched on the recent publication of data from the Danish trial in patients with non-ischemic dilated cardiomyopathy, questioning the role of ICD therapy in this population during the most recent years and based on the secular trends and the improved pharmacological therapies. In regards to cardiac resynchronization therapy, I exercised a myth-busting on some concepts that are currently considered non-disputable in the field of device technology. In particular, whether cardiac resynchronization therapy improves survival, whether 70% represents a magic number of responders, whether hospitalization represents a hard endpoint, and how compliance are centers across the world in regards to CRT in potentially eligible patients. The controversies were based on the observation that all of the trials that have been conducted randomizing cardiac resynchronization therapy versus best optimal therapy were funded by the companies that are producing the devices, did miss an ICD arm, a pure ICD arm in the vast majority of cases, did not enjoy an external adjudication committee, did not perform an entirely intention to treat analysis, or suffered from protocol amendments at some point in time. The variable distribution of these conditions clearly dilutes the value of the study and introduces confounders that may preclude a pure evaluation of the data. For example, SCADEFT, in which ICD therapy was compared with best of therapy in congestive heart failure, was an entirely pure study that was mostly, if not completely, funded by NIH, and also met all the criteria that we have mentioned together. Nevertheless, this therapy has proven effective in the so-called super responders, in whom, however, the underlying conditions is likely represented by a desynchronization cardiomyopathy, which resumes to normal upon resynchronization. All other conditions require better assessment for the future, and I hope there will be more room in the future to establish which patients are likely to respond to this therapy at time of implant.